So today we are going to discuss about inguinoscrotal swellings. So we have different types of inguinoscrotal swelling which include inguinal hernia, femoral hernia. So now today in this presentation we will study clinically how to take a case or how to examine a case of inguinal hernia. So first see inguinal hernia. You can see in the picture the intestinal contents are moving into the inguinal canal. This is inguinal hernia. Intestinal loops or the bowel contents are moving into the inguinal canal. You can see in the picture. This is inguinal hernia because they are moving into the inguinal canal. Direct inguinal hernia and indirect inguinal hernia. It is of two types, okay? Inguinal hernia. So you can see the direct inguinal hernia. It is moving directly without crossing the deep inguinal ring via to the space medial to it. You can see, it is not crossing the deep inguinal ring. That area is called as Hasselbalch's triangle. It is bounded medially by the rectus abdominis muscle, laterally by the inferior epigastric vessels, and inferiorly by the inguinal ligament. So it moves via that area directly. That is direct inguinal hernia, and it is more common in elderly males. Whereas indirect inguinal hernia, it is moving via the deep inguinal ring, then to superficial inguinal ring. You can see, it is crossing the deep inguinal ring also. So that is indirect inguinal hernia, which is more common in young males. So now we will discuss the case. Suppose if a case comes to your OP, so how are you going to take his history and how are you going to examine the case? So we will learn this. So suppose a 58-year-old man who is a known smoker. So first we need to know the age of the patient, because if it is young, then indirect chances are more indirect inguinal hernia, and if the person is elderly, then the chances of direct inguinal hernia are more. Then you have to check whether the person is a smoker or is a non-smoker. So smoking will cause what? Smoking will cause the weakness of the abdominal muscles, so it will increase the chances of hernia. Okay, that person comes to OP with swelling in right, okay, on right side inguinoscrotal region. Since 3.5 years he is having that swelling, and that swelling was insidious in onset and it was gradually progressive in nature, means it was gradually increasing. That swelling was increasing and reducible. Reducible means the person can himself reduce the swelling, that when he applies pressure on that swelling, it reduces. It cannot be, means it moves inside. That is called as reducible, okay. And since it is reducible, so it indicates it is not a hydrocele, because hydrocele is not reducible. Because if that person will come to you with a swelling, you have to differentiate whether it is a hernia or whether it is a hydrocele. So you have to ask for reducibility. Ask the patient to reduce it. If it is reducing, then it is hernia. If it is not reducing, it is hydrocele. Now if hernia is reducing spontaneously, then that is direct hernia. If the person has to reduce, then that is indirect hernia. Okay, if the person is reducing that manually, it is not coming without cuff impulse, then that is indirect. But if you reduce and it again comes out spontaneously, means you reduce the swelling, okay, and then it again comes out spontaneously on its own, that is direct hernia. But if you reduce it and you have to tell the patient to produce cuff impulse, then swelling appears, then that is indirect hernia. Now, what are the aggravating factors which increases the swelling? So those are standing, cuffing, straining, excessive straining, and relieving factors means when it reduces or lying down, the person will feel more comfortable. And no episodes of vomiting and constipation. If the person will have constipation and vomiting episode, that means that hernia is obstructed. Okay, so we have to check the history of vomiting and constipation. If bowel and bladder habits are not normal or the person is constipated, then that will increase the risk of hernia, because constipation will put pressure on the abdomen, so it will increase the chances of hernia. Then you will take his past history, no history of diabetes, asthma you will take, TB, COPD, coronary heart disease, and all this history you will take. Then you will take family history to check if it is significant or non-significant. Then take personal history. Now you have to ask for addictions, okay? He is a smoker since last 20 years. We have already seen that. Now comes examination. So general examination, the person is moderately built and nourished. We suppose that patient which we are discussing is moderately built and nourished, and his vitals are stable. His nutritional status seems adequate. And now you will go for the local examination. So you have to take the consent of the patient first, okay? And you should examine the patient in both standing and lying down position. Why you should examine the patient in standing and lying down position both? Because in standing position, you can differentiate between whether it is inguinal hernia or femoral hernia. Okay, so your marker is pubic tubercle. Okay, you first of all, you check whether that swelling is above and medial to pubic tubercle, then that is inguinal hernia. Or if it is below and lateral then that is femoral hernia. So pubic tubercle is a very important marker. Check for the swelling whether it is above and medial or whether it is below and lateral. Now we suppose that was above and medial, so it was inguinal hernia. Now you ask the patient to reduce the swelling. If swelling reappears on its own, again direct hernia. If swelling appears only when the patient coughs, that was indirect hernia. Now you will palpate the swelling. You look for any rise of temperature there and you ask the patient to reduce the swelling. Never reduce on your own. You ask the patient because patient knows how he can reduce his swelling. Okay. And then ask the patient to cough and you have to check for cough impulse. Now next comes the important tests of inguinal hernia. The first is deep ring occlusion test. In this test, you have to ask the patient to lie down and reduce his swelling. Now with your finger, you occlude the deep ring. Okay. Now you ask the patient to stand up and cough with your finger which is occluding his deep ring. Okay. If swelling appears on its own medially, direct hernia. If swelling appears when you remove your finger, then it appears and that is indirect hernia. So deep ring occlusion test is used to check whether it is direct inguinal hernia or indirect. What you will do, you will first ask the patient to lie down and reduce his swelling. You will occlude his deep ring with your finger and then you will ask the patient to stand up and cough. If it appears without you removing your finger, if it appears, that is direct inguinal hernia. If you remove your finger and then it appears, then that is indirect hernia. The next is ring invagination test. In ring invagination test, you will check whether that swelling hit your fingertip or whether it hits your finger pulp. But this is not that sensitive test and you do not do it in your examination in OP and all. It is not that significant test, but just you need to know about the test. Then comes the Zeeman 3-finger test. What will come under Zeeman 3-finger test? You place one finger on deep ring, one finger on superficial ring and another on femoral ring. You have placed your 3 fingers. Now you ask the patient to cough. Whichever finger will feel the impulse, that swelling, whichever finger will feel, that is where hernia is. If it is on deep ring, it is indirect hernia. If it is on superficial ring, it is direct hernia. And if it is on femoral ring, it is femoral hernia. Now you auscultate. If bowel sounds are heard, then that means it is enterocele. That means abdominal contents are there, intestinal loops are there. Now you will go for abdominal examination. Digital rectal and perrectal examination you have to do in abdominal examination. Now you can see of Zeeman 3-finger test. You can see 3 fingers. One is placed on deep inguinal ring, another on superficial inguinal ring and another on femoral ring. And you will check which finger will feel the impulse when the patient coughs. So it will tell you which hernia it is. Then ring occlusion test. See, you have occluded the deep ring and now you ask the patient to cough. Okay, if it appears on its own, then that is direct hernia. That if negative ring occlusion test, that is bulging of the hernia, it is indirect hernia. Positive ring occlusion test, no bulging of hernia, is direct hernia. That means you will place the finger and then you ask the patient to cough. If it appears on its own without you removing the finger, then that is what? That is direct hernia. If you remove the finger, then that is indirect hernia. Now diagnosis. So what you will write? A 58-year-old smoker with right-sided. It is on right side, incomplete, because that swelling was not, it was till root of the scrotum. It is not till below. That is why it is incomplete. It is indirect. We have already seen it is enterocele because bowel sounds were heard, and it is uncomplicated because there is no problems of like constipation, vomiting and all. So it is uncomplicated, and management is hernioplasty. We will place a mesh there and then surgery is performed. So this is all about clinical case taking of inguinal hernia. Thank you.